Good morning, everybody, and welcome to today's Cancer Survivorship Echo series. Thank you for joining us. Just a few of us today. So first I want to start off and go around and have everybody introduce themselves. So Nirav, do you want to start us off?
Sure. My name's Nirav, and this is Shelly. We are at UNLV Medicine. We're exploring starting a Project Echo here, so we've been trying to attend some meetings. Check out how you guys do it.
Great. Good morning.
Thank you. Good morning.
And Dr. Barry Cole.
Hey, good morning, everybody. Barry Cole. I'm just a retired guy who's still curious.
Thanks. Good to have you. And someone joined by Samsung.
Yes, my name's Therese Litter. I'm a community health nurse with the state of Nevada.
Great. Good morning, Therese.
Good morning.
And then Kimberly Rogers, could you introduce yourself?
Hi, good morning. Can you hear me?
Yep.
Okay, perfect. I'm Kimberly Rogers with the American Lung Association in Nevada.
Great. Good to have you this morning. Thanks.
Thank you. Okay, well, thank you so much for joining, everyone. So today's webinar is on the impacts of tobacco cessation on survivorship. So I wanted to talk a little bit about the Nevada Cancer Coalition and kind of how we came up with the Cancer Survivorship series. So the coalition, in collaboration with Project Echo Nevada, is providing this series to primary care providers as an introduction to issues in cancer survivorship. So the why is today more than 2/3 of those diagnosed with cancer are told that they expect to live at least 5 years after diagnosis. So according to the American Cancer Society, in Nevada, there's currently 120,200 cancer survivors. And in 2019, there's 14,810 people who will be diagnosed with cancer. So this series hopes to address survivors' ongoing needs with improved outcomes and quality of life for cancer survivors. So the Nevada Cancer Coalition, I'm the programs manager at Nevada Cancer Coalition. We are a statewide nonprofit, and we bring together organizations and individuals across the state to collaborate on all things cancer. We provide information and education to both the community and healthcare providers. And we also house the most comprehensive resource directory for cancer patients and caregivers. And we develop and implement cancer prevention, early detection, and survivorship initiatives. So if you have any questions, please go to our website. We have amazing tools for providers, as well as information for survivors. And you can always email me and find my email address on there if you have any questions. So I would like to introduce you to today's presenter, Thomas Iliogia. He is the Clinical Director for Health Initiatives and Assistant Professor of Medicine at National Jewish Health. He oversees clinical programs, training, and quality assurance for 15 state quit lines, including the Nevada Tobacco Quit Line. Thomas has a background in medical social work and addiction treatment, with several years of practice and research experience working in tobacco control and health system change to promote tobacco treatment. So without further ado, let's welcome Thomas.
Thank you. Happy to be here. Do we have the slides up? Perfect. So thank you for that introduction. So what I wanted to talk to you today about is the smoking cessation impacts for cancer survivors. And we'll go through a few different elements of it. I think that will be important. Some of it might be already known, and hopefully some of it is new information. We can go to the next slide. Just wanted to let you know I don't have any conflicts of interest, and that all the medications that I'll talk about today are consistent with best practices for tobacco cessation. And the objectives for today's talk, again, is to talk about the benefits of cessation during cancer treatment, as well as cancer prevention and cessation after cancer treatment as well, for people who continue to smoke. Talk a little bit about the pharmacotherapy treatments for tobacco use and dependence, some of the first-line agents that are recommended, and then talk a little bit about the counseling side, specifically the 5 A's and the Ask, Advise, Refer models, which are evidence-based models for tobacco cessation in healthcare settings. So on the next slide. There was a recent review in the New England Journal of Medicine talking about cancer survivorship, and in one section of it they talked about promoting health for cancer survivors, and they laid out 5 strategies, which were weight management, physical activity, a healthful diet, reduced alcohol consumption, and smoking cessation. And not surprisingly, those are also general health promotion strategies for the general population as well. So, you know, becoming a healthier person generally is also good for promoting health, specifically among cancer survivors. The next slide. One of the things we can think about in terms of tobacco products is thinking about the continuum of harm for people who are using tobacco products or nicotine-containing products. And so you can see on the left-hand side of the screen there, on the most harmful is combustible forms of tobacco like cigarettes, cigarillos, pipes, cigars, hookah, and you can think about them as being more harmful not only because of the sheer volume of chemicals that are included in the smoke, in the mainstream smoke, so the smoke that the user themselves is inhaling, but also on the impact on public health in terms of how it impacts the health of other people around those people who are using these products. So they really are a really harmful product, and perhaps one of the most harmful consumed products on the market today. Not just around tobacco, but generally, they're just really harmful to health. And then somewhere in the middle, you have your smokeless tobacco products like dip, chew. There are many forms of tobacco, including like almost like the Listerine strips that you can put on your tongue so they're dissolvable. Up in sort of the top right there, you can see a can with little paper, looks like little paper pouches in it. Those are Swedish snus packets that have tobacco inside of a little nylon wrapper. And there's some evidence from Sweden that people who are using these have reduced risk around the health effects from tobacco use. And they've actually applied, the makers of Swedish snus have applied to the FDA to get designation as a modified risk tobacco product. So those are the kinds of things that we're starting to see on the market. Not really available here yet, but will be, I'm sure, in the near future. And electronic cigarettes kind of fit in the middle there somewhere as well. You know, we don't really know the true extent of harm from them yet, but they're probably not as bad as smoking, and definitely not as safe as using something like Nicorette, Nicoderm, you know, the nicotine patches and gum lozenges, other forms of medicinal nicotine. Next slide. You know, and we've known for a long time that tobacco and cancer are linked, you know, going all the way back to the first Surgeon General report in 1964, where they're really demonstrating the link between cigarette smoking in particular and cancer. You know, and that was based off of studies that started sort of in the 40s and 50s, where we saw that people who were smoking tobacco had there was a corollary to higher rates of cancer in the populations that used tobacco or smoked it specifically. And then there was a few studies that came out after that demonstrating how tobacco smoke in particular caused cancer. And so the Surgeon General only in 1964 first reported that it was conclusive that cigarette smoking caused a couple of forms of cancer. Notably, I think it was lung cancer in men, and was the big one. But there wasn't even really conclusive evidence at that point of whether or not it was only in men versus in women, et cetera. By 2014, skipping 50 years after that one, and you know, 5 years ago now, the Surgeon General released their updated report showing all the different forms of cancer that were conclusively caused by tobacco use, and in particular cigarette smoking. And today we know that, you know, just under 30% of cancer deaths are attributable to current smoking. And on the next slide, this is a little bit hard to see, but if you want to see the larger image, it's in the Surgeon General report from 2014. On the left side shows all the different cancers that are conclusively linked to smoking. So, you know, sort of the head and neck cancers, lung cancer, but also some that people don't think about, like cancers of the digestive system and the urinary and genital systems, as well as the colorectal. And in 2014, they were conclusively linking for the first time liver and colorectal cancer. So a lot of cancers linked directly to smoking, and then that's to say nothing of all the various chronic diseases that show up on the right-hand side that are also affected, caused by smoking, but also worsened by continued smoking. And so when patients do have cancer, they often have one of these other chronic diseases as well. And so it's just a really, one of the worst things that somebody can do for their health is continuing to smoke. Next slide. One of the things I really like about this graph, and some of you may have seen it before, this was the American Cancer Society presentation in 2013, where they mapped out the per capita cigarette consumption. And what I find interesting about that one is that if you look through all the little peaks and valleys inside that black line, there are little stories of public health interventions that worked or didn't work, and how the tobacco companies were responding and promoting their products and those kinds of things. It's a really fascinating history of cigarette use in particular from that line that I won't go into today. But what I want to point out is the blue and the red lines. And so you can see that the peak of per capita cigarette consumption is somewhere around 1964 when the first Surgeon General report comes out, and that the male lung cancer death rate peaks about in the early 1990s. So some 30 years later. And that's because we know that the cancer effects of smoking generally take 20 to 30 years. It's a really late effect from smoking. And so that by the time somebody quits, often they've already substantially increased their risk of, in particular, lung cancer and all the other forms of cancer. And you can see that women's smoking rate or lung cancer death rate peaks in the sort of the early 2000s. That's because women started smoking at a population level, started smoking much later than men did. And so where men's smoking rates really took off around World War II, women's really started to take off in kind of connected to the women's liberation movements of the 1970s. And so as their smoking rates increased through the 70s and the 80s, their lung cancer death rates didn't peak until the early 2000s. And again, just because of that latent effect of how long it takes for smoking to really have the effects on cancer before we see them. And so it's hard for people to hear the risk prevention message of preventing risk for cancer because it takes so long. We'll move on to the next slide. So when we look at tobacco cessation and cancer, so you can think about it again as cancer prevention, but also cessation during treatment as well as after treatment for people who continue to smoke. So as cancer prevention, we know really clearly that cessation reduces the risk of cancer over time. For somebody who does smoke, if they quit, it takes about 10 years until their risk is 50% of that of a current smoker, and it never really goes down to the risk of a never smoker. So the risk is always elevated for somebody who's ever been a current smoker, which is defined, by the way, as in national surveys as smoking more than 100 cigarettes in a lifetime. So somewhere around 5 packs of cigarettes would consider somebody to be either a current or a former smoker, depending on whether they've used it in the last 30 days. But so we can see that it takes quite a while for the risk to really go down. And a recent study published in the Journal of the National Cancer Institute showed that there was almost a 40% decrease in lung cancer risk after 5 years, even for people who smoked pretty heavy, so more than 10 cigarettes a day. But the risk goes down pretty quickly, but it does stay elevated, basically for a lifetime. The next slide. Why focus on cessation once somebody already has cancer? And I think that there's several reasons for it. One is if somebody is currently undergoing cancer treatment, we know that it improves the treatment effectiveness for quitting. And part of that is related to surgical outcomes. So if somebody's having a surgery to remove a tumor, we know that if they quit smoking for as little as 4 weeks before the operation, they have better surgical outcomes like wound healing, pulmonary complications, so not needing intubation or ICU after the surgery, those kinds of things. So better surgical outcomes, but it also reduces the treatment side effects from radiation and chemotherapy, and also increases their effectiveness. So, for example, with people with chemotherapy, a lot of the drugs that are used are metabolized in the liver, And so smoking increases or basically makes anything that is metabolized by the liver go through a lot faster, which is one of the reasons whenever somebody is stopping smoking, a lot of medications that are metabolized by the liver have to be adjusted in terms of their dose, and, you know, and to manage any side effects that come out of it is, you know, for that reason. And again, if somebody quits once they've been diagnosed with cancer, so in particular for head and neck cancers, we've known for a long time, that study there, Rome in 1993, is, you know, by current standards is getting pretty old, but you know, what they found was that if somebody quit smoking within 12 weeks of diagnosis, they decreased their mortality by 40%, and if they stay quit for at least a year, they decreased their mortality by 70%, and by 2 years, their levels were already down to that of a never smoker.
Thomas, real quick, we have a question here. Does the 100 cigarette 5 packs account for the secondhand smoke that we all had in the 50s and 60s? Fathers smoked in homes, cars, everywhere. Kids passively smoked for their childhoods. Now I can modify my risks, but I can't overcome my childhood.
Yeah, really good point. And I didn't show the second. There is a slide in the or an image in the Surgeon General report, the 2014 50th anniversary edition, that has a separate slide just on the effects from secondhand smoke, or even really environmental smoke today. Beyond just the secondhand smoke, we know that there's also effects for essentially whenever you can smell cigarette smoke, even if it's not from somebody actively smoking, you're being put at risk from tobacco smoke-related chemicals. So some of what we call off-gassing, where the chemicals are being released from walls or from carpets, from clothes. Even those chemicals have health risk effects, including, you know, on the heart and the lung because of the PM 2.5, so the particulate matter. So for the slides that I was showing and the data that I'm presenting is for people who are current smokers, so it does not include people who passively smoked. There isn't really a lot of research showing that people who passively smoked as children, who never smoked themselves and are not exposed to environmental smoke during their adulthood, have increased risk of cancer, but there certainly is for adults who are chronically exposed to secondhand smoke. Most of those studies come from generally wives of husbands who smoked for a long time and smoked indoors, that they had higher rates of smoking-related cancers like lung cancer. And then I see a follow-up question in there. So is it tobacco or the added chemicals that matters? And I'd say it's both. There are specific chemicals in tobacco, the tobacco-related nitrosamines, that when consumed increase the risk of cancer. And that's why, you know, for smoking, it's definitely the worst. However, for people who only use other forms of tobacco, like smokeless tobacco products, they still do have elevated risks of cancer, in particular oral and throat cancers, as well as pancreatic cancers and stomach cancers related to people who, you know, for chronic use of smokeless tobacco products. So it is both. It's, you know, there's a lot of chemicals that are added to the products, but there are also specific chemicals in tobacco that are known to be carcinogens. So I'll move on to the next slide. After cancer treatment, again, so we're looking at still helping people to quit and why. I think that, I forget what the acronym is here, I think American Association of Cancer Researchers, I think, or American Academy of Cancer Research, has shown that, or in their review in 2013, showed that people who quit smoking after their cancer treatment and stay quit decrease their risk of recurrence. And so that's a big part of it, is preventing the recurrence of cancer, but that it also prevents the occurrence of new primary cancers. And so if somebody has lung cancer, gets treatment, and stays quit, then they're reducing their risk for things like colorectal cancer and that. But it also improves survival time. So for people who do go through cancer treatment and quit smoking, they have a longer survival time, and not only live longer, they also have a better quality of life overall. And that goes for smoking cessation generally. There are documented increases in quality of life for people who stay quit. So moving on to the next slide, how big of a problem are we talking about? So in 2010, using national survey data, 54% of people who had a cancer diagnosis were either currently or had previously smoked cigarettes. I see there's another question that's popped up. So setting aside tobacco, Colorado and Nevada are recreational, talking about marijuana. So there is no link, no definitive link yet, I'll say, between marijuana and some of these cancer risks. So the risks are just not quite the same. In terms of cancer risk, there are some, depending on how people are consuming it, if they're chronic smokers, the most common effects from it is sort of like chronic wheezing or asthma exacerbations, those sorts of things. But we haven't really seen anything related to increased risk of cancer among people who have used a lot of marijuana over their lifetime. So we haven't been able to say that. However, what I'll say is that for people who are using both, are smoking marijuana with tobacco, they are still at risk for the disease states that are associated with sorry, and my light, if I close my door and close my blinds, is set on a motion sensor until it goes off. So hopefully the light of my computer screen will be enough to keep me visible. But so it just around cannabis, it's really hard to say that they have the same effects. I think the effects of marijuana are probably more related to the psychoactive components rather than the whether or not it's a chemical risk. When it comes to things like vaping or edibles, the biggest risk that I could see with vaping is that if you're using a product that you're heating up metal components and then inhaling, you do have an increased risk of breathing in some of those metals. They will just ionize and small particles will flake off from the heating elements and people will inhale them. And we've seen that with electronic cigarettes for nicotine vaping. I haven't really seen much, there's not really a lot of evidence for people who are using marijuana for many reasons, including the current legal status at the federal level, so there's not a lot of research dollars for it. And so are these conclusions specific to smoking tobacco or smoking generally? I mean, again, we're not supposed to breathe in smoke of any sort of, from any sort of combustion. You're breathing in particulate matter, which is going to have an impact on your heart and on your lungs. And so the best thing you can do for your health is not to breathe in smoke. That goes for people who are breathing in campfire smokes and all kinds of things. Good clean air is going to be the best thing you can do. But smoking tobacco is still by and far the worst. So going back to the slides, when you look at people who are currently smoking and using tobacco, they look the same as the general population. So people with cancer diagnoses who smoke tend to be a little bit younger because they're still smoking and haven't quit. They tend to have a lower socioeconomic status as measured by income and education, or not having insurance and Medicaid, which again is related to socioeconomic status, but also has additional risk factors for things like having access to treatment, and not only treatment, but also for prevention and getting those health messages about quitting. And at least 50% of the patients who are diagnosed with cancer who currently smoke, so that third of cancer patients who are currently smoking, about half of them make a quit attempt, but the relapse rates are really high, so somewhere between 13 and 60%, and that varies by cancer type. So I'll move on to the next slide. Some of the other risk factors for smoking among survivors is things like having, again, lower education, so less than a college degree, being less than 50 years of age. People over 50 are more likely to quit. Being divorced, separated, or single, which probably is a proxy for social support. So if you have more social support, you're more likely to make better or be able to stick to healthful decisions a little bit easier. Again, people who are uninsured, people who are diagnosed greater than 10 years ago, so maybe some of the salience of having a cancer diagnosis has decreased. Having a diagnosis of cervical cancer is associated with continued smoking, and there's multiple risk factors for that, again, because cervical cancer is also more related to some of these other sociodemographic factors like younger age, lower socioeconomic status, access to treatment, those kinds of things. But also for breast and ovarian cancers compared to head and neck are much higher, and lung and prostate are much lower. which again probably reflects some of the age differences. Lung and prostate cancers tend to be found in people who are older compared to breast and ovarian cancers, but also that men tend to have higher rates of cessation compared to women. So looking at the next slide, some additional factors. So a study from 2013 controlled for some of those demographic factors. Again, found that among smoking-related cancer diagnoses, a non-head or neck cancer were all related to continued smoking, which probably again reflects that, you know, if somebody is smoking and they recognize and it's really clear that the cancer is in the place where they see their smoke going, that it becomes a little bit more salient and perhaps motivates them more strongly to stop smoking, versus things like ovarian and breast cancer, where people might have a harder time making the connection between those types of cancers and the need to quit. But notably in this study, what they also found was that people who had depressive symptoms were more likely to continue smoking, which is again consistent with the general population in terms of psychological distress. And then in their qualitative work on that study, they also found that people who talked more about hopelessness related to their cancer or higher levels of stress and nicotine dependence were also more likely to continue smoking. And I see a question here saying, are we talking about the core genetic vulnerability for breast and ovarian cancer versus lung and prostate cancer, suggesting issues at the level of DNA with tobacco being the catalyst? I haven't seen anything that specifically makes that connection between whether or not tobacco smoke is impacting different cells differently in terms of their overall risk. So I can't really comment on that. It might also, because it could also be, just how distally these organs are from primary tobacco smoke, and whether or not, how much of the chemicals are getting there. So I'm just not sure about that. So I'm not sure that I can answer that question adequately. So look at the next slide. So again, we know that counseling to quit smoking is probably one of the most effective ways, counseling and medication. I'll talk about that a little bit more. And we know that health professional advice to quit smoking increases the likelihood of cessation. That's been demonstrated over and over again. And what's really concerning is that only half of survivors who continue to smoke report having been advised to quit by a health professional. So one of the most effective treatments out there, which is just getting that little bit of advice from a health professional to quit, only half of cancer survivors, so they have a diagnosis that is probably strongly related to continuing to smoke, and only half of them are getting that type of care. And in a survey from 10 years ago of National Cancer Institute designated comprehensive cancer centers, what they found is that, I think there's 58 of them, or were 58 in the survey. Only 21% of them offered no tobacco use treatment at all. So 1 in 5 of these cancer treatment centers was not offering any type of tobacco use treatment. Only 62%, so a little less than 2/3, routinely offered smoking cessation materials to people who use tobacco. And less than 50% of them were actually actively identifying tobacco use among patients. And if you're not asking, how are you going to treat it? And less than half of them actually had staff that were specifically designated as people who would provide the tobacco use treatment. Moving on, okay. And then there may be some reasons for that. Some of the clinician barriers to counseling might be that cancer treatment providers are really narrowly focused on providing the cancer treatment, and perhaps rightly so, that's sort of the acute piece that's in front of them. So they're not talking about other forms of treatment. They're kind of narrowly tailoring on the cancer treatment. However, again, remember that nearly 30% of cancer deaths are attributed directly to smoking. And providers also say that they have inadequate training to provide cessation counseling, which is part of why we need to get out there and make sure that folks like yourselves are getting the training to provide cessation counseling, understanding how to do it. But also perhaps a fear of that discussing smoking for somebody who has cancer will increase their guilt and shame, in particular for things like lung cancer, where it's really clearly people understand that it's caused by smoking. but what I would say is, you know, there's a saying, and I forget who said it, but I've heard it several times, is that people choose to smoke their first and their last cigarette, and that you can really put a lot of the blame on tobacco companies for all the smoking that happens in between, in terms of how they've manipulated tobacco to be more addictive and to keep people hooked and, you know, along with all the marketing that they did to keep people smoking, even though they knew it would kill people. So I see a couple of additional questions that are coming in. After getting their cancer diagnosis, many people stop hearing, so they may have been advised to quit cigarettes, which is absolutely, there's a possibility there. But in late stage disease, smoking cessation is not going to change the clinical outcome. I would say, you know, even at stage 4, quitting smoking is still related to a longer duration of life and a better quality of life. And so I would still say it's never too late to quit smoking, and it really depends on what that person's goals are. You can't force somebody to quit, but it's still important to help people quit if their goals are to decrease their symptoms or they're still accessing treatment for cancer, and they want to decrease their symptoms from the side effects, or to improve things like pain related to cancer. You know, we know that people who continue to smoke report higher levels of pain compared to people who quit. So there's still a lot of reasons and a lot of motivating factors for people who are undergoing treatment, even if they have late stage cancers, to really help them live the best life that they can still at that point. And another question, it could be more, or a question there from Dr. Cole, it could be more efficacy for medications based on shared enzymes. I'm not sure that I can comment on that. I'll move on to the next slide. Talk a little bit about tobacco use, treating tobacco use and dependence. So that's the clinical guidelines, last updated in 2008. I've heard people talking about whether or not we need to do another update on it, but I think that the strategies outlined in there are still pretty relevant. Some of the evidence may have changed over time. But what these guidelines recommend for people in healthcare settings in particular is asking about tobacco use and documenting it in the medical record. If you're not asking about it, you won't know, and then if you don't know, you're probably not going to provide treatment. So we know that just getting everybody to ask about tobacco use from every patient when they come into the clinic or in the hospital, documenting it in the medical record, increases the likelihood that they're going to get treatment and increases the likelihood that then they will quit. Advising cessation at every visit, and this is the idea of every patient, every visit, who is asked about their tobacco use and responds that they are currently using tobacco should be advised to quit smoking or quit using tobacco. And making the connection is really important, to make the connection between their current health condition and smoking, which, you know, is really quite easy to do. If you think back to that slide that I showed from the Surgeon General report, smoking impacts almost every organ in the body, and so it's you know, whatever health complaint that somebody has, there's probably a connection to their current smoking. You know, smoking really is one of the worst things that somebody can do for their health, and for that reason, quitting is one of the best things they can do to improve their health. And we hear a lot that there's not enough time in a clinic visit, or, you know, there's another focus for that visit. But just keeping in mind that a brief intervention, anywhere from 1 to 2 minutes, is effective in helping people make that change towards becoming tobacco free. You know, you can think of tobacco as being tobacco use as being a chronic relapsing condition, and just like you would with any other chronic disease, it requires treatment over time, and it doesn't have to take a lot of time, but, you know, and it probably won't be that one visit is enough, but those brief interventions really do work. And then the providing or referring to evidence-based counseling formats, which include individual sort of in-person counseling, group counseling, and telephone counseling, are all evidence-based counseling modalities. Again, it usually requires multiple interventions. It is a chronic relapsing condition, so it takes multiple interventions to get somebody to the point of being able to quit. The specific counseling skills that are in meta-analyses have been shown to be effective is particularly around problem solving and skill building. Problem solving you can think of as kind of helping somebody identify what their triggers are for tobacco use. Where do they smoke? How are they going to avoid cigarettes? What else do they need to do? Do they need to change their routines? Those kinds of things, which also then lends into skill building, is helping somebody figure out how to manage the triggers, how to manage withdrawals, teaching them how to use nicotine replacement therapy or how to use other cessation medications. Those could be all considered skill building activities. We have a tendency as healthcare professionals to want to provide information to people and tell them everything we know about why they need to quit smoking to improve their health. But that can come across as lecturing, and we know that that's going to be much less effective than if we listen and reflect. Finding out from the person what they're going through in terms of trying to quit smoking and reflecting their experience back to them so that they know that you've heard them. Some of that comes from the motivational interviewing type interventions. So really listening and reflecting rather than lecturing. Combining counseling with medications. Combinations is always key to successful cessation. So some of those counseling pieces, and we'll talk about some of the medications, I think in the next slide or two. And then the other piece of it is that if somebody is unwilling to quit now, using those motivational interviewing or motivational interventions to leave the door open. So that can be things like, without requiring or asking for an answer, saying, can you think about what it would take for you to be ready to quit smoking. So that you're leaving the person with something to continue thinking about, but letting them know that you're not going to pressure them into quitting, that it's going to be their decision, preserving their autonomy, and that you're there to support them and that you can't do it for them. So looking at some of the evidence around counseling, again, as I mentioned, these are the three top evidence-based interventions: individual, group, and telephone. All of them are effective. Group counseling is probably one of the more effective. However, it's really hard to get people to come to a group. So usually you'll have a lot of people who say they want a group. You set up a group and a whole bunch of people will say they're going to come, and then you hold the group and one or two people attend. So even though it's really effective, it's really hard to get people in there. And so even though telephone quitline counseling is one of the lowest of the behavioral counseling strategies, because it's so widely accessible, it's a really important strategy to keep in there. And again, physician counseling is really important, whether it's brief advice or full counseling, which I think they defined as anywhere from 3 to 10 minutes or greater than 10 minutes. Again, counseling is more effective than advice because you're giving essentially a larger dose of treatment. Talking about some of the medications, so there are 5 forms of nicotine replacement therapy. The nicotine transdermal patch, the gum, and the lozenge. That's not actually what the lozenges look like. I just couldn't find a generic image of lozenges, so I used this one. But the patch, gum, and lozenge are all available over the counter without a prescription. They're really safe medications for people to use if they're trying to quit. The nicotine nasal spray and nicotine inhaler are available by prescription only. Not as commonly used, probably because of that, but also not as patients tend to struggle a little bit more with figuring out how to use the nasal spray and the inhaler versus putting on a 1 patch a day and adding some gum or lozenge on it when they need. So in the next slide, just some of the dosing recommendations. So for nicotine patch, it's usually if somebody smokes greater than 10 cigarettes a day, they're starting at 21 milligrams patch. They can use that for 4 to 6 weeks. Stepping down at 2 to 4 week intervals as tolerated, usually to the 14 milligram and then the 7 milligram patch. If somebody smokes less than 10 cigarettes a day, usually the recommendation is to start at 14 milligrams, again, for 4 to 6 weeks, stepping down at 2 to 4 weeks as tolerated. And then for nicotine gum and lozenge, if they're using it as their primary agent for cessation, if you smoke within 30 minutes, the recommendation is to use the 4 milligram strength. If you smoke after 30 minutes, using the 2 milligram strength, using at least 9 pieces a day. And then if you're combining it with the nicotine patch, which is recommended because it increases the cessation rates overall, combining it with the patch as needed to treat cravings, and reminding patients that it's really to pre-treat cravings in some ways. So if a craving usually comes after a meal, is using a piece of gum or lozenge before the meal to help manage the craving that might come, just because it takes a little bit longer for it to absorb into the system. It's absorbed buccally rather than inhaled like some of the other, like a cigarette would be. Some of the non-nicotine containing medications include bupropion, which is both an antidepressant. It's a norepinephrine and dopamine reuptake inhibitor. So it helps to reduce some of the cravings and irritability associated with nicotine withdrawal. Varenicline is the other one, currently only available from Pfizer under the brand name until 2020. It's a partial alpha-4 beta-2 nicotine receptor agonist, which is thought to be the primary location for nicotine dependence. It helps to extinguish some of the cravings and the reinforcing effects from smoking. And on the next slide, the dosing for bupropion, you're starting usually 1 to 2 weeks before the quit date. It starts at 150 milligrams for 3 days, and then moving up to 150 milligrams twice a day, so 300 milligrams a day for 7 to 12 weeks. It can be combined with the nicotine patch to help manage with some of the nicotine cravings, because it's not acting directly on nicotine. Can safely be combined with NRT. For varenicline, it's usually started a week before the quit date, starting at 0.5 milligrams daily for 3 days, then 0.5 twice daily for 4 days, so for that first week titrating up, and then using for 12 to 24 weeks at 1 milligrams twice daily. And all of these medications can be adjusted for side effects, so if somebody's experiencing more side effects from some of these medications, they can be titrated down and usually still have pretty significant efficacy. Varenicline isn't recommended to use with NRT because it's blocking the receptors, so some just wouldn't really get any effect from the nicotine replacement if they're using varenicline. And it's not clear how they would work together, so it's not yet recommended. And so I would say that if somebody's using varenicline, they're supposed to just continue to smoke normally for the first week. And usually what happens is that as the medication titrates up, it extinguishes the reinforcing effects from smoking, and the person just doesn't get anything from smoking anymore, and it's easier for them to quit. There was some concerns about the neuropsychiatric effects of varenicline in particular, as well as bupropion for people with psychiatric illness in particular. This is a big study that was conducted in Europe, predominantly with people from both psychiatric populations and non-psychiatric populations, and what they found is that there was no significant increase in the neuropsychiatric adverse events that could be attributed to varenicline or bupropion relative to nicotine patch or to placebo. And so based on that, the black box warnings on varenicline and bupropion were both removed or are in the process of being removed. If you look at the next slide, you can see the cessation rates from that trial. The varenicline outperformed all of the other medications. I should note, though, that they used only nicotine patch, and in other head-to-head trials between nicotine patch plus gum or lozenge, varenicline has been fairly similar. So they're pretty similar in efficacy. However, it is a very effective medication in both the non-psychiatric and the psychiatric population. So a very effective medication. I will note that Pfizer and GlaxoSmithKline sponsored these trials along with some other public funding, and so that's always a caveat to any medication study is who's funding it. Pfizer again makes varenicline, and GlaxoSmithKline is the big manufacturer of nicotine replacement products. There was also some early concern about cardiovascular safety for varenicline. In a recent trial in JAMA Internal Medicine, this is a pretty large study, I think over 1,100 patients. They did not find any evidence of the use of smoking cessation pharmacotherapies that included varenicline, bupropion, and nicotine patch, that there was any increased risk in serious cardiovascular events during or after treatment. Again, the warning for cardiovascular effects is still on varenicline. It's not black box warning, but it is a precaution for people with cardiovascular disease about whether or not it's truly safe. But I think we're moving in a direction of even if somebody has cardiovascular disease, including in hospitals, new cardiovascular events, those kinds of things, we are moving towards at least starting them on nicotine replacement therapy because the risks of nicotine from NRT still far outweigh the benefits of using NRT outweigh the risks of using it in those settings, because the risk is usually that people will continue to smoke, and that's going to be much worse. Looking at some of the evidence for nicotine replacement, again, the risk ratios compared to placebo are always higher among all the products. Nic combination NRT, as I mentioned, patch plus gum or lozenge, is more effective than any single product, any other nicotine replacement product. Varenicline, again, highly effective medication, usually quit rates of around 40% among patients who are using varenicline to quit. Bupropion is also similarly effective, much less used today compared to, most people want varenicline, maybe partially because it's the new one on the block, but also because it is just a very effective medication. So looking at the provider strategies for how to help somebody quit smoking, the AHRQ guidelines, this is from the Treating Tobacco Use and Dependence guidelines, recommend using the 5 A's. So that's asking about tobacco use and documenting it, advising them to quit, as we've already talked about, and then assessing willingness to make a quit attempt. Is the person ready to make a quit attempt at that time? If they are, helping them through that, providing the counseling, providing the medications, if a prescription is required, writing that prescription, and getting them the help that they're going to need to be able to quit smoking. Again, if they're unwilling to quit at that time, use motivational interviewing techniques or interventions to increase the likelihood that somebody will make a future quit attempt, and then arranging follow-up. So when, kind of making follow-up phone calls to the person at the time that they're on their quit date, and providing support after their quit date to help them manage through the triggers and the cravings. And again, if unwilling to quit, addressing it at the next clinic visit. There's a nice algorithm or a flow chart that comes from, that kind of follows this from the AHRQ guidelines. Just if people want that as the reference, again, it's just ask, advise, assess, assist, and arrange for follow-up. And the other one that is becoming more common in provider settings is to use the Ask, Advise, Refer or Ask, Advise, Connect. You'll sometimes see it referred to as. And the idea here is that if a provider feels like they don't have enough knowledge or skill or time to provide the whole 5 A's, that they can stop after Ask, Advise, and then at the point of assess is ask the person if they'd accept a referral for treatment. And then referring to individual group or telephone counseling, again, providing the medications at that point and sending a referral. We know that active referrals are more successful compared to passive referrals. And usually what that means is a passive referral is sort of giving somebody a phone number and saying, call the quit line. Much better to actually send in that fax referral and get the person over to them for proactive calls. Warm referrals is things like the provider actually makes the call themselves and then hands the phone over to the patient in the clinic or at the bedside to get them enrolled in treatment. Generally results in really high rates of enrolling in treatment. So I'm going to talk a little bit about a resource that is available in Nevada. This is the Nevada Tobacco Quit Line. National Jewish Health is the operator for it. So we deliver the service to people in Nevada who are looking for help to quit smoking. It's funded through the Division of Public and Behavioral Health. All Nevadans are eligible for free cessation counseling as long as they're age 13 or over and are using tobacco. Medications are available to Nevada residents who are age 18 or older. That's based on the guidelines. And in preparation for this Project Echo, we talked to the folks over at the division about because there are eligibility required for criteria for nicotine replacement therapy to get it for free. They're going to open it up beginning in April to anybody who is a cancer survivor. So that's a new feature to the Quit Line. So if somebody is a cancer survivor and is looking for help with quitting, they'll be able to get the nicotine replacement therapy and counseling for free through the Nevada Tobacco Quit Line. How to get there, they can enroll by phone. That's the 1-800-QUIT-NOW. It's routed based on area code. If somebody does have an out-of-state area code, they'll still be routed through. It might go to a different provider first, but they'll still get to the Nevada Quit Line. they can go online. It's NevadaTobaccoQuitline.com. And that leads them through to a web program. There's resources online. They can enroll there. There's also links on there for providers to the fax referral. There's a web portal where you can enter a patient's information to refer them. And it goes directly into our system, and we start making calls out to the person usually the next day, or as long as the referral comes in before midnight, we usually make calls out to them the following day. If you have an electronic medical record that is meaningful use compliant, we are able to set up referrals directly from the medical record over to the quit line, and you can receive progress notes back into the medical record. Fax and web portal referrals get a fax back, so if you enter a fax number in there and you're a HIPAA covered entity, we will send you back progress notes. And one of the other new features on there is that participants who maybe aren't ready to talk on the phone can use there's a chat function. There's a little box that pops up when they get to the website that asks them if they want to chat with an agent. They can start the process there, learn more about the service, and be able to get some of the support that they need to get started. And that's all I have for slides. I'm happy to answer any additional questions. You can also email me, or happy to take phone calls as well if you need some additional strategies on either working within health systems to get people to treat tobacco or to help patients quit smoking. I'm here for that.
Excellent. Thanks so much, Thomas. It looks like, yeah, Dr. Koss, do you have a question?
Yeah, I just have a few questions. One of them is, did you examine the benefits of smoking? This has been all about against smoking, but what are the benefits that you're aware of?
I don't think there are really any benefits from smoking. There are some studies on looking at the benefits of nicotine, in particular for people with, from what I've seen, is people with Alzheimer's disease. They're exploring whether or not nicotine replacement therapy might be helpful with in that population. I think the other one, if I remember correctly, is people with Parkinson's disease, because it's a dopaminergic related illness that and nicotine releases dopamine, that if people are using dopaminergic agents, that it might improve symptomology. Smoking, regardless of whatever effect from nicotine, I would never recommend smoking tobacco as a way of getting nicotine. There are just much safer ways of getting nicotine rather than smoking.
I guess the people who are smoking have found a lot of benefits. They do tell me about the benefits that they derive from smoking. Their social benefits, weight maintenance, it helps them think, it relieves stress and anxiety. But I have another question for you. You recommend evidence-based counseling. Do you think that the people who started smoking started because of evidence? After all, they stuck a foreign object in their mouth, set it on fire, and they suck on it.
Well, I would say they started using tobacco. I want to go back first, though, to the idea of nicotine relieving stress and anxiety. There's not really any evidence that it does that, and in fact, a lot of times what people are calling stress and anxiety is also nicotine withdrawal. And so, because the two are so closely intertwined, it's difficult to say that people who are using nicotine are relieving stress and anxiety versus relieving nicotine withdrawal. And also that people who stop smoking report lower levels of stress and anxiety compared to people who continue. So there are benefits for stress and anxiety by quitting over and above whatever benefit somebody feels they're getting from continuing to smoke.
Well, if they quit, don't you think they'll go into withdrawal, and doesn't that spike anxiety?
Right.
You can't have it both ways. You can't have it, withdrawal, and then have them experience less anxiety and yet experience withdrawal.
Right. So we have to
when they experience withdrawal, they have more anxiety.
Right. So we have to treat the withdrawal, symptoms of withdrawal. So nicotine replacement therapy in particular is a very effective way of treating the withdrawal. So if somebody's using nicotine patch along with gum or lozenge, it decreases the feeling of withdrawal, as do some of the other medications like bupropion and varenicline. I hope that answers that part of the question.
Okay, and what do you think about the evidence-based counseling? I mean, we're dealing with a population that presumably didn't start smoking because of evidence. Approximately 14% of the American population smokes, usually relegated to people who are engaged in, who have mental illness or whose environment entails significant poverty. They previously did not want to smoke. Often they don't want to stop smoking, and they don't have the resources to engage in counseling. So how do you think evidence-based counseling is going to work for these people?
Well,
From a practical point of view, how do you sign them up?
Sure, counseling is effective across all populations for cessation. There, whether it's people with low socioeconomic status, if they're living in poverty, those kinds of things. There are resources, and I want to encourage if somebody has access to a phone, they have access to the Quit line, or if they have a smartphone, they can engage in texting interventions, those sorts of things. There are a lot of interventions available. I'm not sure what's available on the ground in Nevada per se, but there are a lot of regional resources through.
Are these resources free for people who are impoverished and live in poverty?
Generally, yeah.
And if they are free.
The Quit line is a free resource to any participant. There's no charge to the participant at any point.
Very good.
Yeah. And then to address why people start smoking, I mean it's a longer conversation, but I think we have to look at some of the risk factors for it. Most people who start smoking, over 90% of them, or around 90% of them, start smoking before they're at the age of 18. And we know that nicotine has particular effects on the developing brain in ways that, because the brain is going through a developmental phase, it rapidly responds to nicotine in ways that produce addiction. And that's what we're seeing right now with things like electronic cigarettes and vaping, is that people who are teens who are exposed to nicotine at a young, before the age of 18 and really up until the age of 25, are much more likely to become addicted and to continue using. And I would say that a lot of that is related to marketing. It's related to the flavors that are in tobacco products, help youth and young people start using it. I don't think that there are really any benefits to starting smoking, and so I would never recommend to somebody with whatever stress they might be going through that they might want to take up smoking to help manage it. There are just much, much healthier ways of doing it. And tobacco companies would love if everybody used nicotine to help them manage stress, but there's just no evidence that it really is helping them manage stress compared to helping them to manage withdrawal that comes from the addiction from starting nicotine in the first place.
A couple of comments, if I may. This is Barry Cole. Good morning. One, the U.S. government has historically provided cigarettes to troops in combat. For some reason, we don't know what that reason was, but I'm not even sure that today's MREs don't have a couple cigarettes in them. The second thing is, here in Nevada, we've at least gotten the smoking out of the state mental hospitals, and a couple of the private hospitals have already gone non-smoking as well. And my final comment, which maybe ties it all together, is if you've never taken a trip to North Carolina, it is worth going to the Reynolds Tobacco Company and taking the tour, because you see raw tobacco going into a hopper, and then they pour 300 to 600 additives into that tobacco that when it's burned, the products of combustion are over 1,200. So when we talk about the tobacco as we see it in fields, people rolling their own, that's a different beast than this manipulated stuff that people are actually buying as packaged cigarettes. And so, I mean, now we're back to my original statement. Why was the government through World War II, the Korean War, probably Vietnam, actually giving the troops cigarettes? The question Dr. Kloss, I think, was referring to is they perceived some therapeutic value to a group of soldiers hopped up on cigarettes.
Or it's the power of tobacco lobbying. I mean, tobacco companies for many years have been lobbying politicians to make sure that their products are not regulated, that they're not controlled, and that they're widely accessible. And yeah, I mean, so if you look back to World War II, we didn't really have really strong evidence yet about the damaging effects of smoking. And you're right, they were in military rations. And even now, there are reduced prices on tobacco for people who are on military bases. There is a strong push from public health advocates and especially in the Department of Defense to start to limit some of that and to be able to remove some of the subsidies that were there for tobacco to make it cheaper for new recruits. I don't know that they perceived a benefit so much as whether or not it was money going into politicians' pockets for lobbying and so that they could run for re-election. I don't think that they saw any benefit to the troops themselves. It's pretty clear that, and tobacco companies even knew at that point that smoking was killing people, and we know that because we've seen their advertising documents about how they saw teens as replacement smokers because a certain percent would quit and a certain percent would die from smoking, and that they needed more teens to continue to smoke in order to get them there. And they knew that if they could get them as teens, that they had them for a lot longer than if people didn't start to use until they were into their adulthood.
Hey, Thomas, as a psychopharmacologist, what about the idea of using dopaminergic augmentation? So you've got all these young men scared to death in combat. They're 19, they're 20 years old, and you give them a dopaminergic replacement compound that keeps them feeling in a state of comfort. Whether they really were is debatable, but that's the feeling they had.
Absolutely.
Okay.
That's definitely part of it. I mean, nicotine is a stimulant, and stimulants, encourage people to do things that might otherwise be dangerous and that they might otherwise have inhibition around doing. And so absolutely stimulants are helpful for that. There are much better ways.
Over time, so we'll need to wrap it up for the day. Thank you, Thomas. Thank you, everyone, for the great discussion and questions. So we'll be back in, it's 3 weeks from today, actually. So that will be Friday, April 12th, and we're going to be talking about vaccinations for survivors. So hope to see you then. Did you want to talk about the summit?
No, I think we're good. Thank you, everybody.
Thanks again, Thomas. This was great today.
Yes, it was wonderful. Thank you.
All right, bye-bye.